This special episode of CRST the podcast is brought to you by Glaukos.
You're listening to
CRST
podcast
from Bryn Mawr Communications.
Hey everybody, Paul Singh here from Southeastern Wisconsin, glaucoma specialist, and we're here with two really good friends and amazing colleagues and educators. Dave and Seb, why don't you guys introduce yourselves?
Hi, I'm David Stevens. I'm from Fort Myers, Florida at Tyson Eye, practice cataract, cornea, and glaucoma surgery.
Hi, I'm Savak Teymoorian, a cataract and glaucoma specialist at Harvard Eye Associates in South Orange County, California.
Awesome. Thank you, guys. Looking forward to having a great discussion today. You know, we had a previous episode not too long ago where we talked about all the different options that we have, the algorithm and kind of all the new tools that we have at our disposal. Let's focus today on some of the kind of pearls and tricks that you've learned and we've all learned with implanting the iStent inject, the W, the two stents in the nasal angle for cataract patients who have glaucoma as well. And so let's just talk about probably the most important issue that I faced, I think I still face, is really how to get a good view. So David, just talk about the importance of getting a good view and if there's any pearls that you've learned on how to obtain that good view and what does that mean to have a good view?
Yeah, I was lucky to be training in the advent of MIGS surgery. It was really exciting. I learned MIGS, I think, a little more recently than you guys, but no, I'm just kidding. But
we're old, it's fine. Say it.
When I was a resident, when I was a resident, it was really awesome that we were offered the ability to learn iStent in training, and then obviously, going into fellowship, it was very MIGS heavy. So I think patient positioning is key at first to learn how far to tilt the patient's head away from you. And, I tend to, do about 45 degrees away. The key really for visualization, once you learn how to get the patient properly positioned, is not pushing down hard on the eye with a gonio prism and learning how to float the prism on the eye. And there's different lenses. And I think finding one that works well in your hands is important. I use the angled gonio prism with a stabilizer on it. It's the Birdall stabilizer. So I'm a little bit biased there since he was my fellowship mentor, but I think that really helps hold onto the eye. And there's even hands-free disposable gonio lenses. I think, Paul, you use that. And so you can utilize the lens with both hands in the eye, which is really helpful at first to get a good view. The other thing is not pushing down on the eye with your hand that's holding an iStent. And so, floating in the wound in order to maintain the view once you started the surgery is important.
Great stuff. Seb, talk about what does it mean to have a good view? What kind of view are you looking for?
You want to get a good view, just like you want a good dilated pupil for cataract surgery. It really makes a difference in terms of how the surgery is going to go, and typically can really affect your outcomes. Usually when I get asked about pearls and tips in terms of looking at the angle, there's really two types of generations here. There's going to be that first generation of questions is, how do I actually view the angle? And then once you become more proficient at it is, well, how can we strategically put these stents into areas where we're going to get bigger and better benefits from it? So if you're just starting off with angle surgery, you want to get a really good view. You want to rotate the patient's head. And I always say rotate it enough such that when you're looking through the oculars, you really shouldn't be able to see temporal iris. If you are, then you haven't rotated enough. And then you want to rotate that scope about 30 degrees. But glaucoma isn't perfect. Not everyone can rotate their heads. They have cervical spine issues. We have to be able to accommodate for that. Once you do enough of these procedures, you can sort of get a feel for, hey, this patient really couldn't rotate as much as I want them to. I'm going to have to rotate this microscope a little bit more. And after a while, it becomes more of an art than an actual science to it. Then it brings up that second set of questions where now that you've had a really good view, how can you strategically put these stents in areas where you're going to get a better IOP reduction? It's not so much of a matter of getting it into Schlemm's canal is, are there better places to put it? Where are those ostia, right, that you mentioned, Paul? If you can really line them up the right way, you can get one spot on. You're going to get a really good pressure reduction. Looking for areas where there's more pigmentation. And you'll be in better spots once you get the stents put in and you give it a little test. You see the natural blood flow or the blanching of blood flow, and you have a couple of really good videos posted about it. You're in the right spots when you can land those stents in. But just like anything else, you're learning how to drive. First, you're aware of everything. After a while, you're really focusing on higher level things. So take it one at a time, take your time, practice ahead of time, practice with your cataract patients alone if you haven't had much practice before. And then subsequently, as you go, just ask yourself with every case, what could I be doing better? And then just try to get incrementally better as you go along.
Yeah, that's great stuff. And recording your cases really does help. You can look back and see, hey, how was that view? We talk about it getting a good view, that en face view we talk about, that being perpendicular. I really think it's important because sometimes I'll see videos where even I've had a hard time and I'm like, I really wasn't en face, meaning I saw the TM great, but the TM was kind of facing down. I didn't really see the story body band very well, even though it was a nice wide open angle otherwise. And so that's why sometimes you just take that extra few minutes, turn the scope a little bit more, even turn the head a little bit more, and the patient look a little bit more nasally, just to kind of get that beautiful perpendicular view. Because the more perpendicular you are, whether it's iStent or any MIGS, the better chance you have of it seating in the canal the way you want it to as well. So that's really a big pearl that I've learned, just kind of take that time to get that perpendicular view. And you mentioned, Seb, too, getting those 2 clock hours away, or kind of targeting based upon either pigment or reflux of blood. Let me ask you guys, how important is it to get 2 clock hours away from each other? I mean, is there data on that? And do you think it's important, or do you go crazy making sure you get that second one 2 clock hours? Or if you're like clock hour and a half, you're like, not a problem. Dave, what do you think of that?
I mean, I'm not aware of data on spacing between the stents. I'd love to see that if you guys have it. For me, the most important thing is that the stents are well placed, and that I get both seated really nicely in the TM. I'd much rather have 2 stents very well placed with nice blood reflux than really try to stretch the distance between the two and maybe place one a little under implanted. And so I typically, I'm right-handed, and so I can typically go further to the left with stents. And so I'll typically go pretty far to the left so I can maintain that kind of perpendicular orthogonal approach, and then almost straight in front of me or just a little bit to the right for the second stent, so that I'm not coming too much of an angle to introduce trocar bias in the placement. So for me, it's just, can I get these really well placed? Are there, visible large episcleral veins, on the conjunctiva that might be a good place? And then beyond that, there may be a little bit more of a luck involved too, if you really just nail the placement on one of them.
Sure, and that perpendicular kind of trocar bias is really important. Talk about that, Seb, and what does it mean to have trocar bias, and how do you see that real time?
Yeah, for those of you that are familiar with football, it's like trying to kick the ball through the uprights. I know Paul's a big Packers fan there. You guys score more touchdown than kick field goals. But what it basically here is the trocar, that center little piece where the stent is going to go through. You want to line them up based upon the side so it's down the middle. Once it's down the middle, you're in great place to kick that field goal. Go ahead and let it go. And sometimes that opportunity where everything lined up is just an instant. You can't be hesitant about it, because as soon as you see it, go for it. It's just like everything else that we do with medicine. Do it with confidence, because that view isn't going to last. Either you're going to move or the patient's going to move. So as soon as it's lined up, go ahead and give it a push down, get injected, get it seated right. And I want to point out, David really hit something on the head here. You want to get 2 stents that are well positioned. We can sit here and have endless discussions about, in theory, the collector channels are this, that, the other thing. Yes, in theory, but you have a practical real life patient in front of you. You need to get 2 stents well seated, priority number 1. Then we can have these discussions about theoretically how far apart they are. You have to execute the maneuver correctly, though.
One pearl I've used, I use the wound as my kind of stabilizer. So I'm going to David's point. I go to my left first, as much as I'm right-handed. It's a little easier to maintain that perpendicular approach. And I'll use the right edge of the wound, and then kind of go perpendicular, go straight to the left. And then when I do the right stent, the one 2 clock hours away, around 2 clock hours away, I use the left side of the wound to stabilize my hand position. And sometimes don't be afraid to turn your chair. Maybe when you come out after the first stent, kind of turn your chair, turn your angle a little bit to give yourself a better ability to get to that second stent 2 clock hours away. So take your time, no reason to rush. This is the most important thing you guys mentioned. Getting a good seated stent is going to work better than a 2 clock hour away stent that's not seated well. So that's really important. The other thing I want to talk about too is just, how do you practice? How do you train? If you're thinking about, because there's still a lot of doctors out there, there's 40% of doctors who aren't doing cataract MIGS right now, still look at market scope data in 2021. So there's a lot of doctors who haven't done MIGS yet, let alone any other stents. And so I was wondering what your thoughts are on how you train doctors, or how doctors could be trained if they're not in residency anymore. What do they do? So David, any pearls on new docs?
Yeah, I was really fortunate to learn how to do MIGS before I was in practice, like in training. And so I had a lot of supervision in that area. I think, getting comfortable with the view is really important. And then, model eyes are really helpful for the actual device use. They're not going to simulate a patient that's moving or snoring or, different anatomy. But I think doing model eyes to get used to how the device feels can be really helpful, especially when I've incorporated newer technologies in practice since I've been out of training, trying to get a feel for that and how it works. And then I think, having somebody come observe cases who have done those, if a physician can come, or maybe if, even the, local rep can come and guide you through kind of those first few cases can be really helpful.
Absolutely. Great stuff. Seb, any other comments on how you can train, anything that you can do before you start your first cases?
Yeah, and this is the beauty of innovation, but also the challenge is there's only so much you're going to learn in training. At some point, you're going to be out there and practicing and something new is going to come out. The question is, how do you learn it and how do you best incorporate it, especially into your first few cases? And if you're not very familiar with angle surgery, I think doing it at the end of your cataract surgery, just standalone cataracts, put a gonio prism on, take a look at what healthy TM and a healthy angle looks like, appreciate some of the variability, but also appreciate the nuances of how much to rotate the head, how much to rotate the microscope. If you can get those steps down, you're about 80% of the way there, should be enough to get a view. Then with everything else, you're just fine tuning. After each case, ask, could I have done this better? What would that have been? Or what did I do really good? And just try to get incrementally better as you go along. But it's a part of what we have to learn with new innovation coming out is how do you learn to do these new things when you're no longer in a training session?
Yeah, really good points. I mean, asking the rep to help you out, and they'll bring a dry. Most reps and most companies they'll get you kind of dry lab time. They'll let you work with the device, hold it in your hand, get comfortable with it, and then intraoperatively, like you said, Seb, after cataract surgery is done and the non-MIGS case, just turn the head in the scope, just get a good view, and then even take a Singh or some type of even kind of forceps or cannula and just go into the angle and just kind of just pretend like you're kind of working in that area, just to get comfortable with the gonio prism in one hand and your other hand with the whatever device, just so you can kind of get comfortable working in the angle. And that just for the first few cases, because that is probably the number one, I think, issue that doctors are afraid of is how do I get that view and how do I maintain that view as well. And we do have, non-contact, not hands-free gonio prisms. I use the eye prism for the most part because it's a nice wide view, it's disposable, it has a little cutout so it doesn't get in the way of your hand. So sometimes a lot of these gonio prisms like a Schwang Jacobs, sometimes if you're pushing against the wound a little bit there, you can push against your device and it can cause more folds and cause more viscoelastic to come out. So that's why I have to be careful on the kind of where you're holding the prism on the cornea. So these are all little things that you can learn as you start doing more cases, but starting out before you do your first case, just by getting a good view is really important as well. But once you get that view, almost all these MIGS procedures become a lot more comfortable, and learning new MIGS becomes a lot more easy when you start to actually learn how to get a good view as well. Any other comments, just for the sake of time, on how to get a good view or the importance of getting a good view, or any other pearls for the iStent in general? Let's say hypothetically it doesn't go in. Any pearls on what happens if it doesn't go in right away?
Yeah, I think one pearl that I learned in fellowship was placing a little bit of dispersive viscoelastic right inside the incision, which really helps maintain the chamber really nicely and prevent reflux of viscoelastic out of the eye, especially early on learning. If I bounce a stent or I notice it's not seated well, I'll usually go ahead and just go place the other stent where I would normally place it, and then come back and use the other clicks on the iStent inject to fully seat the original stent that didn't look quite like it's where it needs to be. And the only other thing I would add is, places like Academy, ASCRS, have MIGS wet labs, and, have people that come to teach, and for doctors who are motivated to learn new techniques. I was lucky to do cornea fellowship where we learned DMEC, DSEC, but the majority of cornea surgeons had to learn DMEC and DSEC out in practice. And so I think wet labs at conferences were really important for those doctors to learn those techniques and incorporate them once they came back home.
No, that's great. Seb, how about you? And talk about, in case it doesn't seat in very well, and talk about how do you prevent heme in general, reflux or post-op heme?
I think David hit all the good points there, and I just want to kind of add on to what he was saying, is just putting in some viscoelastic, That'll help prevent the heme. But if by chance you do bounce one off, go ahead and put the other one in and then come back and get the first one. And probably my biggest recommendation is, look, this is just like anything else. Just keep practicing. It'll get better. The first couple of cases are supposed to be hard. The first step of learning something new is not knowing what you don't even know. The next step is knowing that you don't know something. So it just work through the process.
I love it. Great pearls here. I was going to finish up a couple pearls that I've learned to prevent heme. One of the things I've learned, regardless of what's the iStent or any other cutting procedure, whatever it might be, is when you, at the end of the case, when you're done, you've removed your viscoelastic, you're hydrating your wounds, filling up the eye with BSS, you overinflate it, right? Keep it pressurized. But what I used to do is I used to get it pressurized, and then I'd say, okay, good, no reflux of blood. And then I would just go and decompress it to where I want it to be, and then we're done. And then very rarely, but sometimes you get some heme next day, right? Not a big deal. It goes away very quickly. But what I've learned to do is bring them to, again, pressurize the eye to, let's say, upper 20s or low 30s, whatever it might be, then slowly decompress it. Give yourself an extra 15 seconds, then do it again. Do a little bit of removal of BSS, burp the wound. Then do it again and burp it down to a level where you want to be, but not right away. Slowly decompress the eye, giving time for the episcleral venous system and the anterior chamber to equilibrate. The second pearl I would say, this is something we can't do for the sake of time now, but I have some videos online, is my dad taught me a technique which sounds crazy and barbaric, but as I use these 6-0 silk episcleral bites for all my cataract and my cataract mixed patients. This is a 6-0 silk suture to the episclera, not a bridal suture, superiorly and inferiorly, and I clamp it to the drape. So the whole time the eye stays perfectly still. So especially when MIGS, when you're turning the head and scope, what happens, the eye moves perfectly with you and it stays stable. So a lot of times if we're doing, let's say, a procedure where even the viscodilating procedure, the eye will torque when you're engaging the angle. But with these stay sutures, the eye does not move when you're engaging the TM at all with iStent or any other procedure. So another way to think about it, if you go online, you can look at some of my videos, you see these little 6-0 silk sutures that allows the eye to stay stable, especially early on. It may be kind of a nice way to help hedge your bets and give you a little bit more stability when you're first starting out as well. But with that said, guys, this was great stuff. For the sake of time, we're gonna call it there, but great stuff. Thank you so much. I'm looking forward to hanging out with you guys again for another episode where we talk about some real life cases. So thanks again. Appreciate it.